A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a presentation on renovascular hypertension. It will be presented by our president, Dr. Giriraj, and would be moderated by our faculty, Dr. Dharmendra Jangir. So I would request Dr. to start his presentation. Yes.
Good morning, respected teachers, my seniors and colleagues. Today, my seminar on renovascular hypertension, moderator Dr. Dharmendra Jangir sir. Introduction. Renovascular disease is a state in which decreased perfusion of the kidneys exists with or without hypertension. Ischemic nephropathy is a state in which decreased GFR associated with decreased perfusion beyond the autoregulatory mechanism of the kidney. Renovascular hypertension is a clinical syndrome in which arterial arterial pressure with or without associated ischemic or hypertension renal injuries occur. In renovascular hypertension, partial or complete occlusion of the one or both renal artery, there is renal ischemia and activation of RAS system and renovascular hypertension is occur. Most common cause is renal artery stenosis, defined as narrowing of the renal artery more than 50% of natural lumen diameter. Most common form of secondary or curable hypertension. Epidemiology. In hypertensive patient, 5% patient have renovascular hypertension, 10 to 20% patient of end-stage renal disease have renovascular hypertension. Renovascular hypertension occur 10 to 45% of malignant hypertension. Renovascular hypertension is moderate or severe hypertension, and very few cases have mild renovascular hypertension. In India, 0.8% of urban population have renovascular hypertension. If the renovascular disease is corrected, it is uncertain that the long-term BP control or preservation of the renal function is occur. Etiopathogenesis, the most common etiology of renovascular disease is atherosclerosis in 70% and fibromuscular dysplasia in 30% of cases. In fibromuscular dysplasia, the medial, perimedial, and intimal relatively 30%, 5%, and 5% cases occur. Atherosclerosis. Atherosclerosis occur in male or female. More common in male, 40 to 70 years of age. Involve proximal one-third of renal artery. 70% of atherosclerosis cases having impinging on renal ostium and 30% 1 to 3 centimeter away from renal ostium. The second cause, fibromuscular dysplasia. Fibromuscular dysplasia commonly occur in younger Caucasian women. It is bilateral. Fibromuscular dysplasia more commonly involve distal one half of renal artery. Medial fibroplasia is most common and is non-progressive. Other cause of renovascular hypertension is endovascular aortic stent migration, post-renal trauma, extension compression, aortic dissection extending into the renal artery, neurofibromatosis type 1 and Williams syndrome. Type of fibromuscular dysplasia. There are three types of fibromuscular dysplasia: medial, perimedial, and intimal in 30%, 5%, 5% cases, and intimal medial hyperplasia in 2 to 3% cases. Medial fibroplasia. Medial fibroplasia exclusively occur in women. In angiography, string of bead appearance occur in medial fibroplasia. It involves distal half of middle main renal artery, and it is non-progressive, not progressed stenosis, not progress to occlusive or deterioration of renal function. Perimedial fibroplasia. Perimedial fibromuscular dysplasia called Gully disease occur in 15 to 30%, 30 years of age patient. Affect only the renal artery. The aneurysm, the string of bead appearance in perimedial fibroplasia is not more than the diameter of renal artery, main renal artery. It is progressive. The stenosis progress to occlusion and deterioration of the renal function. Intimal fibromuscular dysplasia or fibroplasia, predominantly in children and young adult, may result in dissection, arterial wall hematoma, and renal infarction may occur. Involve mainly proximal renal artery, but may also involve the mid and distal renal artery. Like pyramidal fibromuscular dysplasia, the intimal fibroplasia is also progressive, and if left untreated, the progression to stenosis to occlusion and deterioration of the renal function occur in intimal fibromuscular dysplasia. Pathophysiology of renovascular hypertension. To understand the pathophysiology of renovascular hypertension, endocrinologist Goldblatt and colleague gave two model in 1934, two kidney Buncliffe model and one kidney Buncliffe model. In both model, renovascular hypertension occur, but evolution and pathophysiology is different. Two kidney Buncliffe model. In two kidney Buncliffe model, one clip apply on the renal artery of one kidney and contralateral kidney is normal. So sodium retention by the stenotic kidney and excretion by the normal contralateral kidney occur, and euvolmia, and the hypertension is due to angiotensin second induced vasoconstriction. Treatment: unclipping the renal artery or ACE inhibitor or angiotensin receptor blocker. It is the diagram showing unilateral renal artery stenosis. The clip apply on one renal artery, so the ischemia occur, and activation of the baroreceptor in the juxtaglobular apparatus and conversion of the prorenin into renin, and renin act on the angiotensinogen in liver. Angiotensinogen convert to angiotensin first, and angiotensin first in the lungs converted to angiotensin second by the angiotensin converting enzyme inhibitor. Increase renal perfusion in the contralateral kidney by the angiotensin second vasoconstriction, suppressed RAST, and due to pressure, natriuresis and diuresis occur, and volume is euvolumia occur. It is it is diagram showing the vasoconstrictive hypertensive model. One clip apply on the right renal artery. There is renal blood flow decrease, glomerular filtration decrease, plasma renin activity increase. Plasma renin activity increase, conversion angiotensin angiotensin first and angiotensin second production occur, and vasoconstrictor hypertension occur. Next model is one kidney, one clip model. In one kidney, one clip model, clip apply on the single renal artery and contralateral kidney is removed. The solitary kidney secrete renin, activating renin angiotensin aldosterone system, resulting in systemic hypertension. Stenotic kidney will conserve sodium and fluid, produce volume expansion, elevation of the blood pressure, sodium retention, and volume expansion gradually suppress renin release from the ischemic kidney. So renin is decreased. Hypertension in the one kidney, one kidney model is largely maintained by the volume and sodium excess in the presence of normal circulating angiotensin second level. ACE inhibitor or angiotensin receptor antagonist do not result in the marked decrease of the blood pressure. In the treatment of this type model, we unclip the clipped renal artery or give diuretic furosemide. This is the diagram showing one clip, one kidney model, and uh, clip apply on the single renal artery. There is a decreased blood flow and glomerular filtration rate, increased plasma renin, and activation of RAS system, and uh, volume, sodium and water retention, and volume expansion. What to suspect? What is the red flag sign of renovascular hypertension? Patient having severe or refractory hypertension with grade 3rd or grade 4 hypertensive retinopathy, abrupt onset of hypertension in previously normotensive or excellent controlled hypertensive patient, hypertension below the 20 years or more than 50 years or of age, unexplained worsening of renal function when the patient on medical treatment, ACE inhibitor or angiotensin receptor blocker, Paradoxical worsening of the hypertension when the patient taking diuretics, unexplained recurrent episode of heart failure or fresh pulmonary edema, systolic diastolic abdominal bloat radiating to the flank region or peripheral region, and diffuse vascular disease or cholesterol embolization patient having chances of renovascular hypertension. Symptom of renovascular hypertension. In renovascular hypertension, patient having headache, hypertension in young age, very difficult to control, blurred vision, flash pulmonary edema, and kidney not working well, or deterioration of the renal function. Manifestation of the renovascular hypertension, renal artery stenosis, sometimes asymptomatic incidental renal artery stenosis occur, and other manifestation is renovascular hypertension, ischemic nephropathy, or acid-related cardiovascular disease, congestive heart failure, stroke, or secondary aldosterosis. Uh, the mechanism of angiotensin second causes vasoconstriction in vascular effect, hypertrophy, remodeling, endothelin release, prostaglandin or oxidative stress, myocardial effect, left ventricular hypertrophy, left ventricular remodeling or left myocyte growth occur. Angiotensin second causes uh, renal sodium retention and water retention or aldosterone hypersecretion. Investigation for the renovascular hypertension. Investigation, the initial blood investigation, complete blood count, urea, creatinine, random blood sugar, lipid profile, ECG, we done, and non-invasive screening test like duplex Doppler ultrasound, spinal computerized tomography, angiography, and magnetic resonance angiography for capsular renography we done. Magnetic resonance angiography. It is sensitive, non-invasive screening test. Sensitivity of the magnetic resonance angiography is 100% and specificity 71 to 96%. Lesion involving the distal renal artery, intrarenal artery, or accessory artery may missed on the magnetic resonance angiography. Risk of nephrogenic systemic fibrosis increase when the estimated GFR is less than 30 ml per minute. CT spiral CT angiography sensitivity 98% and specificity 94%. Limited in renal insufficiency when the serum creatinine level 1.7 more than 1.7 milligram per deciliter, there is chance of contrast induced nephropathy. Duplex Doppler. Doppler, accurate for those with renal failure, does not require the discontinuation of the antihypertensive or uh, no exposure to potassium nephrotoxic contrast. The disadvantage of the Doppler, time consuming, highly operator dependent, and is a technically difficult test to perform. Difficult to adequately visualize renal arteries in obese patient and in those with overlying intestinal gas. Renal Doppler, usually 7 reading taken from the renal ostium, proximal, mid and distal renal artery, and upper, mid and lower pole of the kidney. Spectral waveform are captured from the artery and the peak systolic volume and resting index are calculated. Normal peak systolic velocity is 60 to 100 centimeter per second. Normal renal artery waveform demonstrate rapid systolic upstroke and persistent forward flow in diastole. Finding of hemodynamically significant renal artery when the peak systolic volume is more than 180 to 200 centimeter per second, or renal artery aortic ratio more than 3.5. This is the table showing normal or less than 60% occlusion, more than 60% occlusion, or complete occlusion. Angiography and intra-arterial distal subtraction angiography, gold standard, indicated if clinical index of suspicion high and intervention is contemplated. Intra-arterial distal subtraction angiography allow less radio contrast to the administer 20 ml or 2250 ml comparatively to 100 ml in conventional angiography. Captopril renography. Oral captopril 25 to 50 milligram is given prior to isotope injection. Determine rate of isotope uptake and washout. Intrinsic renal abnormality limits the washout and curve characteristic when the serum creatinine more than 2 milligram per deciliter. Major criteria for positive test: decrease uptake. When the decrease uptake is comparatively uh, more than 10% or less than 40% of total uptake. Delay peak uptake of the isotope. The normal graph, peak uptake occur in 5 minutes and delay peak uptake after 10 to 11 minutes occur in the captopril renal graph showing renovascular disease. Slower wash out in stenotic kidney or more than 5 minute delay. Renal vein renin measurement may help predict the BP response to renal revascularization. Previously, indicated that the lateralization of the renal vein level in diseased kidney and normal kidney, the level of renal vein renin more than 1.5, showing the response more than 90% of patients. Some clinicians use these measurements to verify the role of a pressure kidney before undertaking nephrectomy. Management of the renovascular hypertension, it is medical management, angioplasty with without stenting or surgical intervention. Medical management is inhibitor or angiotensin receptor blocker, control blood pressure in 90% of patients. Main ACE inhibitor and ARB given as monotherapy. ACE inhibitor control in 80%, and when diuretic is combined in 90% of patient, blood pressure is controlled. Atherosclerotic renal artery lesion may progress with time. 40 to 60% progression occur over 7 years, and half of these occur initially 2 years. Medical therapy may reduce BP below a critical level. In these conditions, we measure serum creatinine, creatinine clearance, blood urea nitrogen, the size of kidney, and blood flow, cortical blood flow by the duplex scanning to prevent the complication like tubular atrophy, interstitial fibrosis, glomerulosclerosis, or progression of the loss of function in the kidney. Percutaneous transluminal renal artery angioplasty, best result when the partial occlusion occur less than 10 mm length and renal ostium is not involved. Improvement in BP may be seen as quickly as 40 to 6 hours after the procedure and commonly seen after 48 hours. Result better in fibromuscular dysplasia, recent onset of hypertension, those with poorly controlled hypertension on medical therapy, refractory hypertension, or unable to tolerate medical therapy, evidence of ischemic nephropathy. Success rate of angioplasty is 87 to 100%. The stenosis rate is 27%. Angioplasty in unilateral atherosclerotic renal artery stenosis. Technical success rate may be low as 70%. Long-term improvement not consistent. Improvement of the hypertension was seen in 86% of patients with unilateral non-ostial lesion as compared to 46% in the lesion involving the ostium. Thrombosis, perforation, dissection of the renal artery may occur. Diffuse atheroembolism occur in 15% undergoing the procedure. Angioplasty in bilateral atherosclerotic lesion, it is difficult to dilate. High complication rate occur. Unsuccessful in 60% patient. The BP improvement rate is 43% and cure rate of hypertension is 8%. Restenosis rate following PTRA in bilateral atherosclerotic lesion is 30%, those not involving the renal ostium and 50% those involving the renal ostium. Angioplasty with stenting. Successful stenting can be achieved in 100% of patients. Restenosis rate is 15 to 25%. 88 success rate uh, when the stent is used and 57 when the stent is not used. But no significant difference in blood pressure can be used after an unsuccessful angioplasty, mainly important in atherosclerotic patient. 5% to 15% complication rate may be seen with angioplasty or stenting. Hematoma formation, renal spasm, reversible acute renal failure in 20% cases, renal artery perforation, occlusion dissection. These complications are occurring in 5%. 3 randomized controlled trial on angioplasty, STAR trial, stent placement and blood pressure and lipid lowering agent for prevention of the progression of renal dysfunction caused by atherosclerotic ostial stenosis of the renal artery. In these trial, 140% is included. Renal ostium lesion is more than 50%. Randomized to stenting and medical therapy versus medical therapy alone. No difference in the degree of BP control. Limitation in 12 cases of 12 out of 64 patients in stenting group be not actually stented due to osteal lesion less than 50%. Astral trial, angioplasty and stenting for renal artery lesion. 806 patients included in this trial, randomized to revascularization and medical therapy or medical therapy alone. No difference in BP control between two groups. Limitation include patients who did not have clinically significant renal artery stenosis or no standard lab result. The CORAL trial, cardiovascular outcome and renal atherosclerotic lesions designed to overcome the limitation of the previous studies, multicenter randomized control trial, medical therapy versus medical therapy plus renal artery angioplasty and stenting. Severe renal artery stenosis defined angiographically as stenosis of the more than 80% of the natural lumen diameter. Reduction of the 2 mm Hg in systolic BP with stenting was noted. Reduction did not translate into a significant determination in clinical event. Risk of stenting did not seem worth with potential benefit. American College of Cardiology or American Heart Association guideline, angioplasty is a reasonable option for hemodynamically significant renal artery stenosis in which the peak systolic velocity is more than 180 to 200 centimeter per second or the renal artery aortic ratio is more than 3.5. Hypertension with an unexplained unilateral small kidney, refractory hypertension, or renal stent placement that is indicated for osteal lesion that meet the clinical criteria for intervention. Window of opportunity defined by the serum creatinine level between 1.5 to 3 milligram per deciliter for most intervention to be successful. This is the algorithm showing evaluation and management of atherosclerotic renovascular disease. Renovascular hypertension is clinical syndrome having hypertension and ischemic renal disease. If the BP is controlled and stable kidney function, optimized medical therapy, RAS blocker, ACE inhibitor, and angiotensin receptor blocker is given. Smoking cessation, aspirin, and statin therapy is given. If the progressive disease or bilateral disease total renal mass is less, then we evaluate by the angiography, CT angiography or MR angiography. If bilateral disease persists, high-grade stenosis or progression of the renal function, then endovascular angioplasty or stenting be done. And if BP or creatinine ratio is raised, the surgical intervention is undertaken. Patient with fibromuscular dysplasia, algorithm showing treatment of fibromuscular dysplasia and renal artery stenosis. The dysplasia not along branch renal artery be done angioplasty. If angioplasty is successful, observation is done by Doppler ultrasound. Or if the lesion involve branch renal artery, surgery is undertaken by bypass surgery. Surgical treatment. Renal artery stenosis will confirm the surgical treatment is benefit in these patients. Patient having renal artery stenosis and aneurysmal or occlusive aortic disease, macroaneurysm of the renal artery more than 4 centimeter, malignant or accelerated hypertension, patient who did not respond to medical therapy or cannot tolerate medical therapy, and transluminal angioplasty is technically uh, impossible. Criteria that will ensure the best outcome of surgical revascularization of a renal artery. The length of the kidney is more than 8 centimeter. Retrograde filling of the distal renal artery, patency of the distal renal artery, viability of the kidney on renography, and minimal glomerular sclerosis or well-preserved tubules on renal biopsy is best outcome occur in these patients after surgical intervention. The surgical intervention is aortorenal bypass. Preferred technique when abdominal aorta is not diseased or atherosclerosis not occurring in abdominal aorta. Other is splenorenal bypass, hepatorenal bypass, or ileorenal bypass. Use of the supraciliar or lower thoracic aorta for the bypass, as these are usually less involved by the atherosclerotic disease.
Thank you, Giriraj. So again, we'll try to briefly summarize the whole topic, and then I would request you to give your queries or anything that you want to ask, all the residents, faculty, anybody if you want. So we know renovascular hypertension is one of the causes of secondary hypertension, right? Of all hypertension, it will account for a very minimal, maybe 1%. And it may be as high as 20 to 30% if we count only refractory or malignant hypertension. So whenever a patient comes to you with a raised blood pressure, and suppose if the blood pressure is very high in a young patient or in a prepubertal, you suspect a secondary hypertension. You will suspect a secondary hypertension if there is hypertension in a person with less than 30 years of age without a family history with no obesity. You will suspect secondary hypertension if there is a sudden rise in blood pressure after 55 years of age and the blood pressure is quite severe, moderate to severe. So all these cases, you would suspect secondary hypertension, and then definitely the hypertensions which are not treatable by medical treatment or by they are refractory or malignant hypertension. So we know all the different causes of secondary hypertension. Besides renovascular hypertension, it could be a chronic kidney disease which can produce hypertension, then pheochromocytoma, aldosteronism, then drug-induced hypertension, Cushing syndrome. All these you have to kind of exclude before you think about renovascular hypertension. There are a few things which can tell you that this could be a case of renovascular hypertension. As I said, patients who do not respond to the usual medical treatment, malignant hypertension, the age group, relatively young age group, and then a patient with diffuse atherosclerosis with a kind of a moderate to severe hypertension. And then if the patient on imaging, you find that there is asymmetrical kidneys, two sides, at least the difference is more than 1.5 centimeter. And then if sometimes on auscultation, if you find a bruit, then also it could be due to renal artery stenosis. And as you said, the treatment is ACE inhibitor and ARB. In fact, this could be diagnostic also. If you find that the patient of hypertension is put on ARB or ACE inhibitor, and you find there is a rise in creatinine more than 30% or 50%, then it typically says that it could be a case of renal artery stenosis or renovascular hypertension. So usually these patients who are put on ACE inhibitors, they can even impair the renal function further. So all these patients of renovascular hypertension may not be investigated. Once we find that these cases of hypertension are treatable by medical therapy, as I said, they need to be optimized on medical treatment only. Only those patients who have malignant hypertension, patients who have impaired renal function, progressively increasing impairment of kidney function, and a young patient where you are suspecting fibromuscular dysplasia. All these patients probably would require further investigations. So to begin with, the non-invasive investigations, we know CT angiography, MR angiography, and a duplex Doppler study. These are the three important non-invasive tests for diagnosing. So The most non-invasive and least harmful would be a duplex ultrasonography, but the main drawback is it is operator dependent and it's not that easy, sometimes particularly in patients who are obese or otherwise. But definitely if it can tell you whether there is a renal artery stenosis. The main thing is the peak systolic velocity, which if goes more than 200 centimeter per second, or if the end diastolic velocity beyond the stenotic area is raised. And third is the resistive index. Resistive index, if it is very high, more than 80%, we all know resistive index is peak systolic velocity minus end diastolic velocity divided by end diastolic velocity. If it is more than 80%, then it tells that their artery stenosis is significant. But again, it tells you the prognosis also, that prognostically, even if you do renal stenting or angioplasty, they may not succeed. So if the resistive index is high, it tells you that it is prognostically not good to do angioplasty in these patients. CT angio and MR angio are very good, very high sensitivity, but not that good specificity. But particularly in patients where the stenosis is on the distal side or intrarenal, they may not pick up the stenotic areas. Again, the main drawback is again the contrast nephropathy with CT and with MR due to gadolinium, the nephrogenic systemic fibrosis that they cause will result in impaired renal function. So you have to be very, very kind of particular about doing these studies, particularly those who have compromised renal function. Of the non-invasive test, we know captopril renography, renal vein sampling, and PRA, plasma renin activity. All these three are not very useful tests as initial diagnostic tests. They may be helpful later to kind of lateralize or find out the renal function on one side, particularly when you do a renography. If the function is very poor, then probably you might do a nephrectomy to help these patients. So these tests are not very kind of diagnostic, and they are not used routinely for diagnosis of renovascular hypertension. As we know, the gold standard is the intra-arterial angiography, where you know exactly where the stenosis is and how much is the stenosis. And usually, if the stenosis is more than 75%, then it is a significant renal artery stenosis which needs angioplasty. Or if it is more than 50% with a post-stenotic dilatation, that gives you tells you that this needs angioplasty. So I think then again, as you said about the surgical management, the bypass surgery could be done in very, very selected patients, though I think nowadays it is done very rarely. Sometimes surgical nephrectomy in a poorly functioning kidney could also be one of the treatment. So this was in a brief nutshell about the renovascular hypertension. So anybody, if you have any query, please go ahead. And Nachiket, if you want to say anything, just anybody? Yeah. Yes, I think, but still, because it's an important topic in the sense because it's neglected mostly. And definitely because we do not care many times these patients of hypertension come. I think if you are aware of this topic or this entity, then you may pick up many of these cases. Yes, Nachiket, please.
Sir, I think that आपने बहुत अच्छी तरह से you summarized everything about renovascular hypertension, and one thing I'd like to say is that 90% of cases of renovascular hypertension, as was told by the resident, they are already can be treated with medicines. So even if in cases of severe renovascular hypertension, maybe the main treatment modality would still be surgery. As far as the investigations goes, the investigations of renovascular hypertension, as Sir has said, they are very, very cumbersome. Like, for example, renal vein sampling and then doing a captable renography, then interpreting a captable renography. Sir, already these patients are on so many antihypertensives. When we were residents, we used to remember ABCD. That is, these patients, or you cannot do these tests on patients who have been taking ACE inhibitors, beta blockers, calcium channel blockers, and diuretics, which majority of patients would require polytherapy for their management, because as Sir has said that it's a malignant hypertension. So by the time that ABCD is, they get washed out from the system, and then you get these investigations done. So I think that now nobody is getting these investigations and directly, because it's easier to do a renal formal angiography and assess the degree of stenosis. So I think that all of them, they would be inside oblivious, and maybe just for if you're trying to do some study, and maybe because an angiography is a straightforward thing to do. Further, as he told us that the complications of stenting themselves, they are so much. Inside his own, discussion, he was telling 50% of patients might have complications. There can be internal dissection. These arteries are already they're pathological arteries, and anastomosing or maybe putting a stent inside these arteries becomes difficult. And the success rate in a few of the studies that he was told, I was telling sir also, is very negligible. We were talking about the one of the trials in which the success rate of stenting was also very, very less. So because it is such a rare injury, we don't see many such cases being presented even in conferences. And even with the volume of work that we have in our department, we don't get much of renovascular hypertension, even though those cases would come by the nephrologist. But yes, it is very important from the exam point of view. And I think that Sir has summarized everything very well. And even if one should know of this entity, and maybe if we look more, if our nephrologist friends look more closely by, then we might start doing some surgeries. But all these years, I think that Sir has the maximum, inside this department, he has seen the maximum number of cases. And I think that it's very rare even for someone to pick it up as a subspecialty and only treat RVH. Thank you.
Thank you, Nachi, for bringing out some important points here. And definitely, as you said, the coral study, the astral study, all these studies do show that when you compare it with medical therapy, they have almost the same efficacy. So most of these patients who tolerate medical therapy, who respond to medical therapy, would continue on medical therapy, and angioplasty is not required in these patients. And definitely, we would not go ahead with this invasive angiography just to diagnose a case of renal artery stenosis. As I said, you first do a non-invasive test, and then only in these positions where we anticipate that we may have to do angioplasty or surgical management to treat that renal artery stenosis, there only you have to go with the invasive intraarterial angiography. Otherwise, you should not do intraarterial angiography in every patient to diagnose renal artery stenosis, because, as we said, the morbidity is quite high even doing an angiography or stenting in these patients. So thank you once again, all of you. Thanks all the residents, faculty members, all who might have joined us today on our Zoom or YouTube. And I thank the moderator, Dr. Dharmendra, Jangir, and Dr. Giriraj once again for presenting. And have a good day. Thank you.
Thank you. You could have had comments.
No, thank you. You better.